Hello everyone, my name is Ting-Wei and my advisor is Professor Wu De. Today I'm going to talk about the topic radiomics of metastatic brain tumor as predictive image biomarker of progression-free survival on non-small cell lung cancer with brain metastasis receiving tyrosine kinase inhibitors. Okay, so this is a project supported by the ASUS in collaboration with Taipei Veteran General Hospital and the NBA lab. Before talking about our thesis, I would first like to give a quick introduction about the lung tumor and the radiomics. So about lung cancer, it is the second most diagnosed cancer worldwide. However, it is the most deadly cancer. The 5-year survival rate of the lung cancer have only been 22%, and for patients with distant metastasis, it is only 7%. However, the survival of the lung cancer patient have been improving. From 2014 to 2017, the median survival have increased from 8 months to 13 months, and this is major because of 3 reasons. First is the early detection, and the second is the different treatment strategies such as immunotherapy, and the third is because of a more precise classification system. And with more precise classification system, we could give the patient with the optimal treatment they needed. And it is the major topic that we want to research, which is the more precise classification system. So first, I would like to introduce about the pathology classification system, which is the 2015 WHO classification of lung tumors. We could see that the most common adenocarcinoma is of epithelial origins, and it could be further classified into the hepatic form, micropapillary form, solid form, or papillary form. However, the classification has several disadvantages. First is that it is qualitative, and also the mixed type of histological type matrices, such as the patient may have hepatic form, solid form, micropapillary form together. And the third is that about the small surgical specimens, that we could only get a small specimen of the patient clinically, and it may not be representative of the whole lung tumors. And the fourth is that pathological specimen cannot reflect the whole clinical course of the lung cancer. So, aside from a pathology classification system, there are also the clinical classification system, such as the 8th edition of the TNM staging of lung cancer system. And it has major 3 categories: the T, the primary tumor; N, the lymph node; and the M, the distant metastasis. And it majorly accounts for the size, the location, and the number of the tumors. And we could classify patient into different subgroups, such as the 1A, 2A, 2B, the 3A, 3B, and 3C. However, the simple TNM classification is not enough. We have known in the recent years that genetic factors also account for lung cancer. So here is a small picture of the whole guideline. So for the advanced stage or metastatic disease, there are 3 kinds of treatment: the chemotherapy, the target therapy, or immunotherapy. So if the patient have undergone a molecular testing with EGFR positive, we could give the patient with first to second generation tyrosine kinase inhibitors. However, here is the problem: is that most of the patients will progress, and the median of the progression time is 9 to 13 months. So this is the major topic that we are going to research. It is that we would like to construct a prediction model to using the treatment data to predict that whether the patient will progress quickly or progress more slowly after we administer the tyrosine kinase inhibitors. So why do we like to choose this kind of population, which is the EGFR mutation non-small cell lung cancer? It is because that in the Asian-Pacific subgroup, the higher frequency of EGFR mutation is observed in the non-small cell lung cancer, and among this subgroup, the EGFR mutation rate is highest in the non-small cell lung cancer in Taiwan. So this is why we choose this population. So here is the table of the tyrosine kinase inhibitors. We could see that there are a total of 3 generations, and third generation ositinib have been only recently introduced to the clinic. So we have only a few data available, and it is not, and we have not sufficient data to analyze. So in our study, we only focus on the first and second generation, which is gefitinib, iratinib, and afatinib. We could see that the odds response ratio is approximately at 50 to 80%. It may vary according to different studies. However, there are two major disadvantages of a target therapy. First is the adverse effect. So the adverse effect is commonly seen in the after administration of the target therapy, including skin disorder, fatigue, diarrhea, elevated liver enzymes. The second disadvantage is that it is the cost of the target therapy is quite high, and it may be a huge burden to the national healthcare insurance system and also to the patient themselves. So in our study, we focus on the EGFR mutation non-small cell lung cancer with brain metastasis, and we chose this population for 3 reasons. The first is that for patients with EGFR mutation, they are more likely to develop brain metastasis. And the second reason is that for patients with brain metastasis, the prognosis of the patient is usually poor. And the third reason is that the different treatment strategy of the clinical usually need evidence, and evidence mostly comes from randomized controlled trial. However, randomized controlled trial have strict indication criteria, and for patients with brain metastasis, they are usually excluded from the randomized controlled trial. So it is important for us to do some study for this kind of patient, so we can handle the patient more precisely in the future. So here are some routine examination before we administer the tyrosine kinase inhibitor. We will use this data to construct our model in further. So the brain MRI is for detection of the brain metastasis, and the CT is for staging of the primary lung cancer and the whole body bone scan for detection of the bone metastasis, and some laboratory tests for detection to see the liver function, the renal function, the inflammation status, and the nutrition status of the patient, and some genetic study and pathology. Okay, so after talking about lung cancer in clinically, we would like to introduce radiomics, which is one of the major tools that we use in our research. So the radiomics, how do we calculate the radiomics? First, we'll take an image such as the CT, and we'll do a resolution adjustment to resample the computer tomography to isotropic. And okay, so after that, we will manually delineate the primary tumor, which is the biggest tumor of the patient, and we manually delineate it in a 2D format in different sizes. So finally, we will get a 3D segmentation, and we use the segmentation of a primary lung tumor to calculate the features such as the histogram, the geometry and texture, and the wave-back features. So the features that we calculate is in adherence to the IBSI, the Image Biomarker Standardization Initiative. So they have provided a digital phantom. So according to the calculation of our professor, we calculate the radiomic feature we calculate is same as the reference that they provided, so that the formula of the radiomics that we use in our study is in adherence to our international guideline. So finally, we have a total of 8 topics that we will wish to study, and some we have completed and some is still in progress. So first is that we would like to use some pretreatment factors to predict the prognosis, and second study that we focus on a patient with brain metastasis to predict their prognosis, and the third study is that we would like to use pretreatment factors and first follow-up factors, and we would like to use a short-term response to predict the long-term prognosis. And the fourth is that we would like to use some pretreatment factors to predict the toxicity. And the fifth study that we would like to do meta-analysis, which is another kind of study to analyze the evidence of the different kind of pretreatment factors, especially the image biomarkers. And in the sixth study, we are also doing some research on the peritumor vessel radiomics. And finally, in the seventh study, we will to facilitate the automatic process of the whole radiomic process, that we wish to use some deep learning model to do the primary tumor segmentations. And finally, we would like to use the deep learning model which that we used in the segmentation to also to predict the survival, so that the final deep learning model can both segment and predict survival together, which is the multitask problem. So, however, today, due to limitation of time, we will only talk about the second study which we have recently finished, which is using pretreatment factors to predict the progression-free survival of patients with non-small cell lung cancer with brain metastasis undergo TKI treatment. So here is the pickle of our study. The population is Spanish EGFR mutation non-small cell lung cancer with brain metastasis treated with tyrosine kinase inhibitor. And we would like to compare the radiomics on brain metastasis with the prognosis index to predict prognosis index. The outcome is the progression-free survival, and the time is 2 to 3 year follow-up. And the study is a single-center retrospective cohort study. So here is the inclusion and exclusion criteria of our study. The inclusion criteria is the patient with brain metastasis, non-small cell lung cancer patient with brain metastasis treated with targeted therapy between 2018 and 2019. And we collect laboratory data, pathology data, the CT data, and the MRI data before dosing time. And we exclude other mutation, the third generation TKI, and patient without complete clinical information. Also, we exclude patient without brain metastasis and without available MRI image. So finally, we have a total of 72 patients. And here is the overall flow chart of our study. First, we segment the primary tumor on the contrast CT and the metastatic brain tumor on a T1 weighted, T2 weighted, and T1 contrast weighted MRI image, and we calculate the radiomics. And together with the clinical features, we undergo a 3-stage feature selection technique. And after that, we feed it to 6 different kind of survival model and do some model selection and parameter tuning. Finally, we evaluated our model with the time-dependent ROC curve, the ROC curve of the median progression-free survival, and the Kaplan-Meier survival curve. So here is the feature that we selected. We first input it with T1 weighted, T1 contrast weighted, and T2 weighted and contrast compared tomography. We first do the wavelet decomposition and get 8 kind of decomposition wavelet image, and together with the original image, we calculate the 16 first order feature, 8 size and shape feature, 21 grade level concurrence matrix space feature, and 11 grade level round matrix textural feature. And finally, the 16 histogram of local binary pattern features. So for feature selection, we have a total of 3 stages of feature selection. In the first stage, we select feature with the Cox proportional Hauser model, and we select features with a p-value smaller than 0.05. After that, we remove collinearity with a variation inflation factor bigger than 5. And finally, we select the features with a Cox proportional Hauser model again, but this time we use a multivariable model to fit all features together. And we use 5-fold cross-validation repeated for 10 times so that we have more robust result. And the evaluation includes the concordance index and the time-dependent error AUC at our median progression-free survival, which is the 311 day. So we could see that from the validation accuracy, the simple Cox proportional Hauser model actually have a superior performance than the machine learning model Fast SVM and the deep learning model CoxCC. It may because of the small sample of our data set. And we could also see that when combining the clinical features with the computational CT features and the MRI radiomics feature, that it had a better result. So for optimal feature number, here is the training and testing validation accuracy of the Cox proportional model and the Cox deep learning CoxCC model. You could see that the deep learning CoxCC model because the model is more complex. It has been overfitting from different very low number of features, and for the simple Cox proportional Hauser model, the optimal feature number is about 8 to 9 features. Okay, so aside from the clinical features and the radiomics feature, we also have input our model with a prognosis index that have been used in clinically, which is the RPA, DSGPA, long mode GPA, and the M long mode GPA. It is different kind of prognosis index to calculate the prognosis of patients with brain metastasis, while they focus on more and more specific population. Majorly, they account for the age, the KPS, which is performance status, and primary tumor control, brain metastasis, intracranial metastasis, and genetic status. So here is our result. Our results show that compare with the clinical index with metastatic brain tumor, it has better predictability than the clinical only, and also better than the clinical index with the radiomics of the primary tumor. However, the clinical with dual radiomics, which is the clinical with the primary and the metastatic radiomics, did not differ significantly from the clinical and metastatic tumor, and we think that it is majorly because of the smaller data set that we use. If we have more data set, that we could achieve better results with the clinical, the metastatic tumor, and the primary tumor radiomics. And here is the final 9 feature that we select: the unstaging, the EGFR mutated status, the histology status, platelet level, blood urea nitrogen level, diagnosis, specific GPA, and two radiomics feature of the brain T1 weighted brain radiomics, brain metastasis radiomics, and T1 contrast brain metastasis radiomics. So we could see that if we cut off the patient with the median progression-free survival, which is 331 days, the estimated Kaplan-Meier curves could be differ significantly. And here is the personalized estimated survival curve of different patients. We could see that for a patient with higher risk. Okay. So here is the personalized risk curve estimation. Okay, so compare. Okay, so here is our final model, which incorporates both the clinical, the radiomics, and the prognosis index, and it has shown to be the time dependent AUC curve is higher than the different clinical index, and also it is higher than the clinical with metastatic radiomics. And okay, so here is the ROC curve of the median progression-free survival, and our model have achieved finally a AUC of 0.87, and if we cut off the patient with the model output to stratify the patient to the high risk group and a low risk group, that we could see that the Kaplan-Meier survival curve could be differ significantly with a p-value smaller than 0.0001. So in conclusion, for patients with advanced stage non-small cell lung cancer with brain metastasis, the MRI radiomics of the brain metastasis may predict the progression-free survival, and the Cox proportional hazard model integrating the brain metastasis radiomics, the clinical feature, and a prognosis index may provide reliable multi-time progression-free survival prediction for patients with advanced stage non-small cell lung cancer and brain metastasis receiving EGFR TKI treatment. And our thesis have been submitted to Computer Methods and Programs in Biomedicine and is currently under reviewing.